My name is Andy Bauer. I'm a pediatric endocrinologist at the Children's Hospital of Philadelphia and the director of the Thyroid Center. And today I'll be presenting a talk on the update and management of differentiated thyroid cancer in pediatrics. I first want to thank the president of the Arab Thyroid Association, as well as the scientific committee, for this honor to present to you, and hope that you find this interesting and welcome any questions at the end during our discussions. I'm also honored, of course, to be part of a esteemed group of other pediatric endocrinologists who are presenting on other topics of pediatric thyroid disease, to include nodules and congenital hypothyroidism. These are my disclosures. The top one will not be applicable to this talk, but I currently am co-chairing the American Thyroid Association Pediatric Guidelines. So some of what I will talk about today will be in the guidelines, which should be submitted and hopefully published by the end of this year. But some of them are also my opinion. So we're going to start with the World Health Organization histologic diversity of thyroid carcinoma, really to set the stage of where we were and where we're going. We'll follow that by the incidence and behavior of papillary cancer, talk about what we accomplished, I think, as far as stratification of care, especially for radioactive iodine in our 2015 guidelines, and then move into the majority of the talk, which is where can we continue to stratify care beyond radioactive iodine to include the evaluation of nodules, surgical management, as well as medical management. So thyroid carcinoma in its most simple form is separated into differentiated thyroid cancer, which we're all familiar with, which is follicular and papillary thyroid cancer with similar distribution in pediatrics and adults, papillary being the most common. Within papillary, it can be sporadic, radiation-induced, or familial, which can be both similar to sporadic follicular and papillary. Radiation-induced is almost universally papillary. There's poorly differentiated cancer, which we do see in pediatrics, and thankfully we do not see anaplastic thyroid cancer. And then, of course, medullary thyroid carcinoma, which in pediatrics is most commonly associated with multiple endocrine neoplasia type 2. In the fifth edition of the World Health Organization, there's been a further stratification. And so there's now high-grade thyroid carcinoma, which is either differentiated or poorly differentiated, which we are also seeing in pediatrics. And there's been some separation of some of what had been previously thought of as differentiated thyroid cancer, but has been separated mostly because of the molecular biology. So oncocytic cell carcinoma, which is typically, which was previously called Hürthle cell carcinoma, is associated with changes in alterations in DNA, mitochondrial DNA. So it's a completely different molecular pathway than differentiated thyroid carcinoma. And the same with cribriform rural thyroid carcinoma, which is a Wnt pathway rather than a MAP kinase PI3K pathway derived form of thyroid carcinoma. For radiation-induced, which we will not spend a lot of time on today, we've known about the modifying variables. The most frequent were the dose of radiation besides the field of radiation. And then younger age seemed to be associated with an increased risk for thyroid nodule and differentiated thyroid carcinoma development, as well as shorter latency to develop PTC. An article that came out in 2021 further differentiated radiation-associated papillary thyroid carcinoma by Lindsay Morton and her group at NCI, and really defined that radiation-induced PTC is mostly a fusion-driven cancer, with RET and NTRK3 being the most common fusion oncogenes associated with radiation-induced PTC. Younger age has been further delineated and is most commonly thought of as the highest group is less than 5 years of age at the time of exposure. And because it's a fusion-driven carcinoma, there is an increased risk of regional and distant metastasis. For familial, there's been some recent updates to guidelines. So the American Association for Cancer Research and one or two other articles in Clinical Cancer Research have published updated guidelines on PTEN hamartoma tumor syndrome, Dicer-1 syndrome, and familial adenomatous polyposis, which is the APC form of papillary thyroid carcinoma, cribriform rural variant. Familial non-medullary thyroid carcinoma has not had a recent update and still is a form of inheritable thyroid carcinoma for which we do not have a germline, reliable germline alteration that's been identified. PTC is further divided now into 14 types, and I think that really highlights that we can't look at each patient and apply a general approach to care. We need to look at each patient, and while we have general ideas to the evaluation and management, we have to stratify per individual patient. And follicular thyroid carcinoma has been further defined as minimally invasive, angioinvasive, and widely invasive, which is also how oncocytic carcinoma of the thyroid is also described. So for this group, we don't need to highlight the differences between an adenoma and a carcinoma. In pediatrics, we thankfully typically only see minimally invasive or angioinvasive. And again, we won't spend a lot of time on this, but it's an ongoing challenge because we still don't know what the number of vessels, capsular vessels with tumor thrombi in them really increases the risk of distant metastasis. And for the most part, those metastases may not be realized or identified for 5 to 10 years after diagnosis. So many of our patients are undergoing lobectomy and then not a completion, and then we need to figure out how to follow them for 5 to 10 years when the data doesn't support that thyroglobulin is the most reliable or specific marker. For papillary thyroid carcinoma, of course, we know non-invasive, invasive, metastatic. The one thing that we always talk about in pediatrics, and I try to emphasize, is that there really is a predictable pattern for lymph node metastasis. So level 6 to 7, and then into the lateral neck, levels 2, 3, 4, and 5 rarely. And patients with lateral neck metastasis have an increased risk of hematogenous metastasis to the lungs. All these levels are evaluatable by ultrasound preoperatively, and it really, really is important and incumbent on us, the endocrinologist, before sending them for FNA, that we identify if there are any abnormal lymph nodes in the lateral neck so that they can be FNA'd so we can have optimized surgical planning. This includes level 6, 7. There's enough space between the inferior edge of the thyroid lobe and the sternal notch to ensure that those lymph nodes are also adequately interrogated with the thyroid ultrasound transducer. In general, patients with papillary thyroid cancer in pediatrics have been described as having a high rate of different of regional and distant metastasis compared to adults, if you look at the upper right of this slide. And because of these high percentages of patients with the risk for metastasis and the presence of metastasis, there's been a push to approach pediatric patients a little bit more aggressively as far as surgical and medical care, and because of in an attempt to decrease recurrence. But I think that, again, this is the old way of approaching it and not the new way. To be, transparent about it, in 2015, we didn't adequately stratify papillary thyroid carcinoma. We didn't talk about 14 different types. We talked about PTC as a one entity, and it was one approach for all. Most patients we recommended have a total thyroidectomy, and most patients would benefit from radioactive iodine. And that type of approach has been continued in other guidelines since the original publication of our guidelines in 2015. But we've all recognized that pediatric patients have low disease-specific mortality, and anyone under age 55 at most can be a stage 2 in the AJCC staging system because of the low disease-specific mortality. So even patients with pulmonary mets are considered stage 2 under age 55 years of age. So in 2015, I think we did an adequate job as far as trying to stratify radioactive iodine. The goal of the guidelines was to maintain low disease-specific mortality, reduce complications by developing thyroid centers of excellence for pediatrics, and of course, to avoid an increase in recurrent disease. We developed these ATA pediatric risk categories, which describe the risk of persistent or residual disease after initial surgery in an attempt to stratify which patients would benefit from radioactive iodine. And the ATA low risk category, which was defined by lymph nodes in the central neck, were the patients that we described as not having any benefit from radioactive iodine. At the time, we didn't know how many lymph nodes defined low risk, which has now been further delineated, which I'll show you in a subsequent slide. We took this approach on in the United States. This is an article from our practice showing that we had about 50 patients at the time of this publications that did receive radioactive iodine and 45 who did not, both ATA low risk, and there was no difference as far as outcome and excellent response at 1 year or at last clinical follow-up. And this article now is several years old, and this continues to be the trend that we see. Not giving radioactive iodine to this low risk group does not result in an increased risk of residual disease. There's been a study out of MD Anderson which further supports this, published in 2024, which even included some patients with lateral neck disease, N1B disease. One can argue that really requires a center as good as MD Anderson, where the pre-surgical and the surgical clearing of the neck is highly complete. But in that situation, there may be a group of patients, even with lateral neck disease, that do not benefit from radioactive iodine. And this, of course, has also been shown in adults, and this is the 5-year follow-up from the very large prospective study that Lebalou et al. Have published. This is the most recent one in Lancet 2025. So moving forward in 2025, how can we further stratify care? You've had one lecture on nodules, so I'll go through nodules very quickly just to really reinforce my belief in somatic oncogene testing. But the goal is that we don't FNA patients with low-risk nodules, and we do identify patients with invasive disease that would benefit from thyroidectomy and radioactive iodine, and maybe even some medical therapy with systemic therapy. And we use ultrasound cytology, somatic oncogene analysis to really define and further delineate care. The ATA risk levels will be updated, and we will include dynamic risk stratification in our new 2026 ATA pediatric guidelines. So the appropriate selection for FNA is really critical. We all know that many of us are using the Bethesda system, and we all know that it's a 6-tiered system, so it really is important who you select for cytology. Within that system, as you look here, the risk of malignancy within indeterminate cytology is higher in pediatrics than adults, and the range of the risk of malignancy within atypia of undetermined significance and follicular neoplasm is even more broad in pediatrics than adults. In a publication that we just had in JCEM, looking at about 2,728 FNAs in pediatric and young adult patients, 991 with histologic confirmation. We even showed that within each indeterminate category, the risk of malignancy may be higher the younger the age of the patient. So for AUS, 67 versus 42%. When we look at differences in age, and 71 versus 49% when we look at patients with differences in age. So again, the age does play a factor when we think about risk of malignancy and indeterminate cytology. But having each of us learn how to at least read ultrasound, if not perform ultrasound, is also critical in pediatric endocrinology. We're the providers that refer patients for FNA. We're the providers that typically have to interpret and act to refer to surgery. Each center is a little different. Some of the surgeons are more actively involved early on, but learning how to read ultrasound is really critical. I've been using point-of-care ultrasound since 2017. I perform about 700 a year. And if you look at the number of patients that I send that end up with benign cytology, it really has decreased. It's allowed me to stratify who I'm sending for FNA. And so we have courses. I teach one at CHOP, and we also have courses that we've taught at Pediatric Endocrine Society meetings, as you can see in the upper right. The other thing we've introduced is rapid onset evaluation. So in addition to bedside confirmation for sample adequacy at the time of FNA, our microscope is video connected to our cytopathologist, and we get a preliminary read. So we've had a marked drop in we've never had a high percent of unsatisfactory samples, but it allows us to then in real time perform an extra pass so that we can perform molecular biology if the preliminary shows atypia of undetermined significance or follicular neoplasm. So there's many benefits to ROSE if this can be incorporated into your practice. It helps increase the adequacy rate, decrease non-diagnostic rate, and it can reduce the amount of time that the patient, and we use sedation, conscious sedation, is under sedation to obtain the sample. So our non-diagnostic rate, and this is over 800 or so pediatric patients for FNA, is less than 1% over the last 15 years of practice. The molecular biology is really playing a bigger role now in pediatrics, and so it's a relatively quiet form of cancer, thyroid carcinoma, and it's very predictable as far as the oncogene and the cytology and the final histology. And we can use this information to not only confirm what is read as the cytology, which is very subjective, but also help plan surgical planning. So oncogene panels provide objective data to increase the reliability of preoperative evaluation. This is really important and which should hopefully decrease that broad range of risk of malignancy in the indeterminate categories for pediatrics. In general, the somatic oncogene panels are the ones that are most helpful in pediatrics. So if we identify an oncogenic driver, it increases the likelihood of a neoplasm or a carcinoma. And while the data is not anywhere near as robust, if you use a comprehensive panel and you do not identify a known thyroid oncogenic driver, it can take a lesion with atypia of undetermined significance, which is about a 15 to 20% risk of malignancy, and lower it to less than 5%. So it really is critical to incorporate this into practice. Gene sequencing classifiers are less data. There's one publication which I list here that was just came out. It is not a large cohort, so I think further research is needed. So there's only about 30 patients with the benign sequencing classifier, and only 9 of those 30 had histologic confirmation. So very preliminary data, but it does look potentially promising. And so, as I mentioned, there is a collinearity between what the ultrasound looks like, what the cytology is going to be, what the somatic oncogene is going to be, and we can use that then to plan surgery because it predicts histology as well. So these lesions, which are solid, smooth margins, no punctate echogenic foci, are likely to be benign or indeterminate. They're likely to have a RAS dicer1 or PTEN alteration. And if they are malignancy, they're most likely to be minimally invasive FTC or encapsulated follicular variant of PTC. In contrast, these lesions, which are infiltrative, have very irregular or invasive margins, and multiple punctate echogenic foci and have lateral neck metastasis, are highly likely to be Bethesda 5 or 6, are highly likely to have somatic drivers to include BRAF E600E and the RET, NTRK, and other fusion oncogenes. And ultimately, infiltrative PTC is either going to be classic to include tall cell, diffuse sclerosing, or widely invasive follicular papillary thyroid carcinoma. So we can use this oncogenic information to decide with the cytology if lobectomy is the best first approach. And this is from the pediatric chapter in the World Health Organization's fifth edition. And to consider total thyroidectomy, not that every patient needs it, but to at least consider it for patients that have suspicious for, consistent with malignancy and an oncogenic driver, which supports an increased risk for invasive disease. The benefits of lobectomy in pediatrics are quite high to reduce surgical complications and potentially reduce the need, likely reduce the need for lifelong levothyroxine therapy. So in pediatrics, lobectomy should be considered for a patient that has indeterminate cytology, a low-risk oncogenic driver, and if on histology we find minimally invasive FTC or encapsulated follicular variant, many of those patients can then be surveilled without completion thyroidectomy. Even some classic PTCs, especially T1A PTCs, these small PTCs can be managed by lobectomy with prophylactic central neck dissection to really understand what the invasive or metastatic potential of that tumor is. We've all had patients with small tumors like this that have lateral neck metastasis. So if you see that, of course, total is the initial approach, but if you do not, a lobe with a central neck should be considered. So we use this information and to help stratify completion thyroidectomy, but also to help stratify the use of radioactive iodine. So I am a believer in prophylactic central neck dissection for those two reasons in pediatrics. This is the draft of the ATA risk levels, and so less than or equal to 5 lymph nodes after lobectomy with a central neck dissection or after total with a central neck dissection will help stratify if you need a completion or if the patient would benefit from radioactive iodine. If you have a low invasive somatic oncogene, but again, cytology that's indeterminate, you have a RAS dicer1 PTEN, because of the low likelihood of central neck metastasis, you can avoid the prophylactic central neck dissection for that cohort of patients. This has been supported in adults looking at RAS versus BRAF. We do not see RAS very commonly in pediatrics, typically Dicer 1 and P10, um, but it's the same. And so we've published on this in 2024. If we look at the rate, central neck dissection for low versus high invasive, the likelihood of lymph node metastasis in the central neck is quite low for lesions for somatic oncogenes that are considered low risk, as you see listed here. So this has all been summarized in an article that we published last year in JCM. So this is the integrative approach to the evaluation of thyroid nodules, where we look at the sonographic features, which help predict the cytology, which likely correlates with the somatic driver, which helps then direct the approach, the surgical approach, whether it's a lobectomy with prophylactic central neck dissection, or total thyroidectomy. And then further, after the surgery is completed and you have the histology, then you can use this information to decide if you enter surveillance or completion, or if the patient would benefit if they've had a total from radioactive iodine. Again, for the ATA second version that should be out this year, this is a draft of the flowchart, which will also show these types of options for lobectomy versus total thyroidectomy, using the cytology, using if the somatic oncogene had been performed and what the result was to help stratify surgical approach. We are also using non-surgical approaches to benign lesions, and so cysts can be managed if they're cosmetically bothersome or physically bothersome with percutaneous injection of ethanol, so through interventional radiology. We are starting to recommend ablative techniques for benign lesions and even considering some ablative techniques for minimally persistent thyroid carcinoma to include ethanol or fiber optic thermal laser or radiofrequency ablation. Just to wrap things up, because I'm about 2 minutes over now, medical therapy wise, again, which will be mentioned in our guidelines, we are using oncogene specific inhibitory therapy for select patients in pediatrics. We all recognize that pediatric patients with pulmonary metastasis are very often not cleared of their disease just by using radioactive iodine. So we have some patients that have avid but progressive. We have some patients that have radioactive iodine refractory but progressive disease. Clearly, these patients benefit from systemic therapy. But even patients that at first pass, if we just think about radioactive iodine and look at the publications in the last 5 years, the ability to clear pulmonary mets simply with radioactive iodine is very low. Less than 5 to 10% of our patients with moderate to high burden diffuse micronodular pulmonary metastasis will be cleared of disease with radioactive iodine alone. So we had been using non-specific tyrosine multi-tyrosine kinase inhibitors, but now we're using mostly RET and NTRK specific inhibitors to include selpercatinib and larotrectinib. Some patients we use as neoadjuvant therapy if they present with morbidly invasive disease. Some patients we use as neoadjuvant prior to the first dose of radioactive iodine, and some patients we use as adjuvant for progressive refractory disease that had already received radioactive iodine but are progressing despite either being avid or if they're refractory. And so just an example for anyone who hasn't had a pediatric patients, these drugs cause regression very, very rapidly within 1 to 3 months, and they also are associated with an increased enhancement of radioactive iodine avidity, even some redifferentiation if they didn't have avid disease. And so this is another one of our patients that had classic, micronodular disease, what had low avidity. With selpercatinib times a year, although we now typically use it for 6 months, we cleared most of the structural disease on CT. It still showed increased avidity. And then we administered radioactive iodine, and the patient has now been very stable with evidence of really no return of the pulmonary metastasis. Many of our other patients have reduction in nodules, but not clearance of the pulmonary nodules. So in 2026, our guidelines should come out at the end of this year. We will then work with the Thank Foundation and GPED, the Global Pediatric Endocrine, to try to take the multiple pediatric guidelines that are available internationally and to try to create an approachable international set of guidelines that can be managed or can be deployed in different clinical situations depending on the regions of the world where we have patients that we're trying to care for. There's a thyroid special interest group through the Peds Endocrine Society, if anyone is interested in joining. And I'll wrap things up by just thanking my team at my hospital, Children's Hospital of Philadelphia. None of my patient care or publications happen without a lot of people supporting us and our patients. And with that, I say thank you and look forward to if you have any questions.